Good morning, everyone. Thanks for joining us on this webinar series on COVID-19 clinical updates. Before we get started, we'll do a little bit of introduction to the format of the webinar and also an overview of the webinar series. But before we get started on that, I'd like to turn it over to George Cybery from USAID for some opening remarks.
Great, thank you so much, Mike. I just wanted a couple of minutes to first welcome everybody from the implementing partner clinical staff and clinicians who are providing care to COVID patients in many countries. And to also thank Dr. Lipnick and the team at UCSF. We're thrilled as part of our support from USAID through the STAR mechanism that they've been able to reproduce updated, clinically important and very webinars and other resources that will help everyone, I hope, in continuing to provide excellent care as we manage through this COVID epidemic. Really looking forward to today's webinar, and I'll turn it back over to you, Mike. Thanks.
Thanks, George. Before we go to the talk, I just wanted to provide a little bit of orientation to the format and also a couple of nuances to the way we've set up the Zoom for this meeting. Again, today's talk is going to be focused on updates in COVID-19 therapeutics. So just a few housekeeping issues. The webinar today is going to be available in English and in Spanish with live translation. The Spanish translation can be accessed by looking at the menu bar for your Zoom window. You should see an interpretation icon. And if you click on that, you can toggle between Spanish and English. Everybody by default is on mute, but you can raise your hand if you'd like to speak or ask questions, and we'll talk a little bit more about the timing for that. If you have any issues accessing the Spanish language, please direct chat to me or to Lauren Wall, and we can help get you oriented. For the webinar today, we'll also be utilizing the Q&A function. So during the talk by Dr. Tien, which we'll get to in a few minutes, please feel free to submit any questions through the Q&A. Please use this over the chat if possible. We'll be answering the Q&A questions live, and for some, we might save them to the end to do via discussion with Dr. Tien. We are recording this so that we can share with those who weren't able to attend today. And if you'd like to access that, please feel free to contact us and we'll share that information with you shortly. Just a quick disclaimer that the intention of this webinar is for educational purposes and to provide up-to-date information, but it is not clinical consultation. So the webinar series that this is part of, we had begun in January with a quick update and overview on lessons learned for respiratory care in COVID over 2020. The intention of this webinar series is to provide additional clinical technical assistance to implementing partners for USAID's Oxygen Ecosystem project, which is ongoing and evolving. These webinars are going to take place on the second or fourth Tuesdays of each month, and the topics are a work in progress. We welcome any feedback or suggestions so that we can tailor these talks to make them most useful to the implementing partners as part of the project. The speakers for this series are members of the STAR-UCSF Technical Advisory Group that we have put together for USAID. The members of this team range from respiratory therapists to nurses to physicians to scientists from a diverse series of countries and disciplines. And so we really hope that we can put together webinars that meet the needs of the implementing partners, and the feedback from you all will be extremely important to help us do that. So we would request to please send us topics. The email address is at the bottom, and we'll share other mechanisms for being in touch with us. So just to set up the webinar for today, I wanted to share this image. This was recently published in Nature. It's an estimate of the number of new publications that are coming out related to COVID-19. In blue, at the blue line, are preprints, and in orange are the estimates from PubMed and Dimensions database of all COVID-19 papers. This was up through the end of 2020. And as you can see, the number is rapidly approaching almost 200,000 publications, which is just an incredible amount of information to navigate and to understand what is going on with the COVID-19 pandemic. In prior global health, public health crises, sometimes it's a lack of information that we suffer from. During COVID-19, it's been quite the opposite. I wanted to share one of the tools that we've been working on to try and help navigate this flood of information, and that is this COVID guidelines dashboard, which as of today is available in English and in Spanish and can be accessed through the QR codes on the left side of your screen or by going to opencriticalcare.org. The dashboard provides a synopsis of the latest guidelines from leading authorities and also shows where there's agreement and where there's disagreement. We're working to add in new institutions in the coming weeks from South Africa, from India, from around the world to again show where there is diversity and how data are being interpreted and how data and practice are being implemented, which is ultimately the most important part of this response. Another resource just to highlight briefly is covidprotocols.org, another part of a project in partnership with Brigham and Women's Hospital and Partners in Health, supported by USAID and STAR. This is an attempt to try and bring together, again, what is a lot of information on COVID and keep it current, available in multiple languages, and have relevance to resource variable settings, which is often an afterthought for a lot of the content that's being created for COVID-19. The protocol site is relatively straightforward. You can search for any topic that you like or navigate in the left-hand menu. Over the next week, the majority of the site will be available in Spanish as well. As of now, chapters 1 through 5 are available, and the rest are coming soon. So without further ado, I'd like to introduce Dr. Phyllis Chen, Professor of Medicine at UCSF in the Division of Infectious Disease and part of the STAR-UCSF USAID Technical Advisory Group for the Oxygen Ecosystem Project. Dr. Chen is an NIH-funded researcher. She leads some large and very long-standing studies for the NIH. She also is currently part of the National Institute of Health COVID-19 Treatment Guidelines Group, which is setting guidelines for the NIH. It's my great pleasure to welcome Dr. Chen. And without further ado, I'll turn it over to you as we talk for the next 35 minutes or so about updates in COVID therapeutics, some of the implications and what's on the horizon. We welcome any questions that you have again in the Q&A, and we will follow Dr. Chen's talk with some live Q&A as time permits.
All right, thank you, Mike. And I'm really excited to be here for me early this morning to speak about this. And so what I'm going to do today is provide updates on current therapies for COVID-19. So I will do actually a review of some of our current therapies and then just point out updates where they have occurred and talk about some of the new drugs or ways of using some of our existing drugs in new kind of ways. All right. So I hope you can see the top of this slide. So the first thing I wanted to do was to review the COVID-19 disease stages, as we have found that this is really important in informing treatment and when we should be starting certain treatments, and especially when treatment should be started. So this first depiction just shows the stage and severity of COVID-19. So as you know, there is an asymptomatic, pre-symptomatic phase where people have a positive SARS-CoV-2 PCR test, but no symptoms. And then people can have mild illness or symptoms of fever, cough, taste, smell changes, but there is no shortness of breath generally in this phase. And then there's a moderate phase where where you have lower respiratory tract disease, but your oxygenation on a pulse oximeter remains at 94% or greater. And then you can have severe illness when your oxygenation goes below 94%, your respiratory rate is over 30, and you have lung infiltrates on chest imaging. And then this can progress to critical illness when you have respiratory failure and shock. And so generally people, with severe or worse illness require hospitalization. So throughout the talk, there are medications that are being developed to be used, as an outpatient. So not when you're in the hospital, or, when you go into the hospital. And then once you're in the hospital, if you're in the intensive care unit. So I wanted to talk a little bit about the disease pathogenesis, because your symptom presentations is associated with the pathogenesis of the disease. So usually the viral load, or this is the level of the SARS-CoV-2 virus that's circulating in your blood, occurs at its peak level right before symptoms appear. And then as soon after that, the body's immune response kicks in, and that leads to immune activation and inflammation. And that's what you can see in the red. And that tends to come, later down the line when, you may be hospitalized or on your way to the hospital. And then the potential therapies that are now being used, and also new ones that are being tested and developed, include antivirals, and it parallels with when you see the peak levels of viral replication. And then there's also antibody therapy. There's several new updates in that area, and then drugs that will decrease inflammation. And one of the other issues that we have been trying to figure out what to do is anticoagulation, because in several of the reports of people with COVID, there have been issues with blood clots, leading to multi-organ issues. So I will touch on these areas in terms of the therapeutic area. So I wanted to begin by talking about Remdesivir. So as many of you know, Remdesivir has really become a mainstay of therapy for the hospitalized COVID-19 patient requiring oxygen. And it is the only antiviral agent, actually the only agent that has FDA approval in the United States for COVID-19. And a lot of the approval was based upon a randomized controlled trial called ACT-1 that was led by the National Institutes of Health, or NIH, and it compared Remdesivir with placebo. And so what they found, the key results, were that Remdesivir was associated with a 50% faster time to clinical recovery. So it was 15 days in the placebo group to recover and 10 days in the Remdesivir group. And they also found that participants in the Remdesivir arm also experienced 8 less days receiving oxygen, also found that they had lower progression to non-invasive and invasive ventilation, and there was a significant mortality benefit in those on low flow oxygen. So the drug was generally safe. There were, fewer adverse events actually than in the placebo group. And then there was a better response if given within 10 days of symptom onset. So the figure below just shows the effect of Remdesivir on time to clinical recovery. And you can see amongst the different categories, the 4 being equivalent to not receiving oxygen, 5 being receiving oxygen, 6 receiving high flow oxygen or non-invasive mechanical ventilation, and the score of 7 being receiving mechanical ventilation or ECMO. So the red box just highlights that this was actually the greatest benefit, at that particular stage. when you were receiving oxygen. Right. So, with the FDA approval of Remdesivir in the United States, additional data or more data came out, and this is from the Solidarity trial. And this is a trial from the UK. And it actually showed slightly different findings, but I'll walk through the table below and we can talk a little bit more about those findings. So Solidarity was a large, multi-center, pragmatic, open label trial that was conducted in the United Kingdom, and it had over 11,000 participants, of whom close to 3,000 were on Remdesivir and close to 3,000 were just getting usual care. And what they found was that there was actually no benefit of Remdesivir on in-hospital mortality. I do want to remind you that the ACT-1 trial in the United States found that actually Remdesivir improved recovery time. And maybe in a small group, it improved hospital mortality. So if you look at the graph on the right-hand side, it just shows that there is no difference in mortality. The blue line being the controls, the red line being Remdesivir, and they're just right on top of each other. So that's just to highlight their findings. But I do want to point out the information in the table below. I know it is pretty busy. The top part kind of shows the data from Solidarity, and then the bottom shows the data from ACT-1. We couldn't put them side by side, but they're like on top of each other. So what you can see is that there may have been a mortality benefit in the low flow or high flow oxygen. And that's, you can, in the Solidarity trial, which has the red box around that area. And if you look at the big black box, the size of the box means the sample size. And so you could see for the low flow or high flow oxygen, it was going in the direction of Remdesivir having a benefit, but it wasn't statistically significant. So if you look at the ACT-1 data, which is below, and I've highlighted the data in the green box, in the low flow oxygen arm, you do see it is significantly going in the direction of Remdesivir being better. So then placebo. And so some of the differences could be how the studies combine the groups. So like in Solidarity, the low flow and the high flow were together. And in ACT-1, they looked at the data for the low flow separately from the high flow oxygen. So generally speaking, I think the trends in Solidarity don't, go against the data from ACT-1. So this is just some of the take homes, and just to summarize the Remdesivir data, given the results from ACT-1 and the results of Solidarity. There is clinical benefit from a randomized controlled trial in terms of clinical recovery. The mortality benefit was not seen at all disease stages, but there was a significant mortality benefit in those on low flow oxygen in ACT-1. And it appeared that Remdesivir was safe. There are less side effects compared to placebo. But the issue is the cost, the IV administration requirement, and access. And I think those are important considerations for the United States and globally. So what we don't know is if Remdesivir in the ICU right now might show a benefit in patients if patients were followed longer than the 15 days that was specified in the protocol. And then how late is too late to start antiviral therapies? And if there is an additive benefit of Remdesivir plus anti-inflammatories, although this is now being actively studied in clinical trials, and we do know that there is a benefit of Remdesivir plus Dexamethasone, which I will talk about later. And so the difference between the conclusions of Solidarity and Remdesivir did lead our United States Food and Drug Administration, or FDA, to point out their conclusions from looking at the two trials. And so ultimately, they said the Solidarity results do not refute the findings of benefit to patients. Okay, so I want to turn to talking about convalescent plasma. This is another therapy that has been studied actually for a long time for a number of different viral infections. But what convalescent plasma is you take the antibody-rich part of the blood without the red cells from a person who is recovered from COVID-19 disease. And the convalescent plasma is thought to reduce virus burden when you give it to someone who does have the disease, but it also may have anti-inflammatory activity. So observational data suggests that convalescent plasma is safe, and the benefit is when it is administered early in COVID disease and with high antibody concentration. And randomized controlled trials also suggest some limited benefit unless used very early, such as within 3 days of symptom onset or 1 day of hospitalization. So the figure on the right just kind of shows the process by which we obtain the convalescent plasma. Oops, sorry. I just need to remove all right. So blood is, collected and run through a machine that separates the antibody containing plasma in a process called apheresis. And then the convalescent plasma is collected, and then the rest of the blood is returned to the donor. And then the collected convalescent plasma is then given to a COVID-19 patient through transfusion. So just the convalescent plasma take home is that it's generally safe. It's best to use very early, and you must have a high antibody titer in the plasma. So the limitations are the ability to access convalescent plasma, and also to determine whether or not what you have shows that there is a high titer of antibodies. And of course, IV administration is also a limitation. So convalescent plasma may actually be replaced by more targeted therapies, for example, monoclonal antibodies. And I'll talk a little bit more about the monoclonal antibodies in the next couple slides, but I do want to say that just last week, the FDA did further limit the authorization of the use of convalescent plasma to those with high titer COVID-19 convalescent plasma, and it is to be used only for the treatment of hospitalized patients early in the disease course. So that, can create another limitation in trying to get patients, with early disease into the hospital. So I'm going to turn now to the monoclonal antibodies. And so these are laboratory produced antibodies that are directed against the spike protein of the SARS-CoV-2 virus. And this spike protein is the protein that facilitates the attachment and fusion of the virus into the host or human cell, specifically lung cells that lead to the respiratory problems that we see. So on the left, this is just a figure showing how monoclonal antibodies are produced. You first take blood from someone who is recovered from COVID-19, similar to how you get convalescent plasma. Then you fish out the cells that produce antibodies to the key portion of the novel coronavirus spike protein. And then that is used to block infection. And so several on antibodies have been combined as an antibody cocktail. And it is generally given intravenously, but it's also currently being studied as a subcutaneous injection, which will really overcome some of the limitations with the intravenous setup and use of this drug. And it's being evaluated across the spectrum of COVID disease. So the inpatient, the outpatient, and even as prevention after exposure. So it's generally well tolerated, although there has been a rare risk of an allergic reaction. Oops. So these are the two most well-studied monoclonal antibodies. And one is from the company Lilly, and they have a product called Bamlanivimab. You might have heard this. This is a single monoclonal antibody, and the other is from the company Regeneron, which is a cocktail of two monoclonal antibodies. And we've, of course, heard a lot about the Regeneron product because Donald Trump got this product when he had COVID. And so the NIH ACTIV-3 studies that used these are using monoclonal antibodies versus placebo in hospitalized patients. And so these two studies are just showing that in hospitalized patients, actually, they were halted for a lack of efficacy, and there may have been a safety signal benefit, safety signal issue. And so these two were halted. And ACTIV-3 is studying a lot of different monoclonal antibodies. And so actually it's still ongoing. At UCSF, we are actually part of ACTIV-3, and we're now studying 3 new monoclonal antibodies from 3 different other companies. So this is just showing some of the data from the Bamlanivimab now that was used also for outpatient therapy for COVID-19. So in the study of the outpatient, it was given to people with mild to moderate illness within 3 days of a COVID positive test. And in this particular study, they looked at 3 different doses of the monoclonal antibody from 700 milligrams up to 7,000 milligrams. And on the right, it just shows that in the 700 milligram and in the 2,800 milligram arms, there was a reduction in viral load, but it was only significant in the 2,800 milligram arm. And then they also showed reduction in hospitalization and emergency visits. And on the figure on the lower right, it also appeared that symptoms, there was a decrease in the number of symptoms that people had in the monoclonal antibody arm as outpatients. So despite the not great results in the hospital, in the outpatient setting, there has been some positive result. And similar to Bamlanivimab, the Regeneron monoclonal antibody cocktail or combination has also seen some positive results as well. And so they also studied a very similar population of people with mild to moderate COVID disease, 1 or more symptoms, and a diagnosis within 3 days. For their study, they looked at 2 doses, 8,000 milligrams and 2,400 milligrams versus placebo. And on the right-hand side, you can look at the figure looking at the decrease in the viral load. So this is the SARS-CoV-2 viral load that was significant in the monoclonal antibody arm, which is the red and green lines. Those are the 2 different doses. So it shows that there was no difference by dose, and it was better in the placebo arm, and specifically in people who were seronegative. So they had an antibody, they had antibodies that were negative to SARS-CoV-2. And so when you look on the right panel of the figure, those were people that were serologically positive for SARS-CoV-2. You don't see the effect there. And so they also showed modest reduction in ER visits and hospitalization. So, the data from Lilly and Regeneron led to an authorization, an emergency use authorization for the monoclonal antibodies for patients that were at high risk. And the criteria for high risk is shown in the box on the right. I won't walk through all of those. And they also needed to be administered in patients who had symptoms for 10 or fewer days. And, for an outpatient, it also needed to be infused over an hour with 1 to 2 hours of monitoring. And again, this was in the outpatient setting. And so I think for many institutions, this has been done in the emergency room. And the supplies were limited and allocated through our Health and Human Services. So the magnitude of clinical benefit has some question, and the role of the baseline antibody status wasn't really addressed. So this led to the NIH COVID guidelines to say that there was insufficient evidence for or against its use, and to only consider for those at highest risk. So, just in conclusion for these monoclonal antibodies on the outpatient front, this was a step forward to start thinking about outpatient therapies, but this particular drug is unlikely a game changer given the number of limitations to its use. So more recently, just actually in the last couple of weeks, there have been press releases from these two companies about the use as post-exposure prophylaxis. So this is in the prevention of COVID disease in patients who have been exposed to somebody. Sorry. So for the bamlanivimab, interestingly, they actually tested a much higher dose at 4,200 milligrams IV. So the dose that seemed to work, and the dose that actually was approved for outpatient therapy was 700 milligrams intravenous. Now for the post-exposure, they're testing 4,200 milligrams. And this is versus placebo in those with a COVID negative test. And this trial was done mainly in nursing home residents and then staff members of congregate settings. And so the data really was that overall there was a lower frequency of symptomatic COVID-19 in people in the monoclonal antibody arm versus the placebo arm. So specifically in the 299 nursing home residents, there was an 80% reduction in symptomatic COVID-19. And then there were 0 deaths in the people that got the antibody versus 4 deaths in the placebo arm. So similarly, for the Regeneron monoclonal antibody, which is known as casirivimab or imdevimab, they tested 1,200 milligrams. But I think what's interesting here is they tested it as a subcutaneous injection versus placebo. And so this is just some of their preliminary data from 400 patients. And it did show reduction in infections within 7 days, 100% prevention of symptomatic infections. And then in 10 people with asymptomatic infections in the monoclonal antibody group, there was a markedly decreased peak virus level, and then the duration and also a reduction in the duration of viral shedding versus the 15 people that had asymptomatic infection in the placebo group. So the take home here is that, again, this is a promising, application of monoclonal antibodies for people who need immediate protection. So this could be a nursing home resident in the setting of an outbreak, or in someone who might respond poorly to the COVID-19 vaccine. So these could be immunosuppressed patients. So the limitations here, mostly with the bamlanivimab right now, is the delivery of the drug. But I think bamlanivimab, Lilly, the company that's making the drug, is looking into dose reductions and decreasing the delivery time from a 1-hour infusion to about 20 minutes. So we'll probably hear more updates from them in the very near future about this drug. So I want to turn now to talking a little bit about dexamethasone. As many of you know, it is now the mainstay of therapy for people who are critically ill. So we're going to turn now to talking a little bit about treatment for people who are hospitalized, and could be on high flow oxygen, mechanical ventilation. And this is just showing the data from the recovery study out of the United Kingdom, where they showed that the strongest survival benefit when using Dex was in the mechanically ventilated arm for people who were on dexamethasone versus usual care. And that is shown on the figure on the left, where the red line is the dexamethasone, the black is the usual care. Now, when you move into the group that were on oxygen only, you see that little difference between the dexamethasone arm and the usual care arm kind of narrowing in terms of the mortality benefit. But there does still look like there is a signal for mortality benefit. Once you get to the panel on the far right, which is in people who have did not require oxygen, you see now that the dexamethasone arm is actually above the usual care arm, suggesting that there might have been harm in terms of mortality. So, some of the limitations to this study was that there were no details on the impact of dexamethasone, by level of oxygen support. So high flow, low flow, outside the ICU. And there's no data on adverse events attributed to steroid use. But there have been several other, studies, including a WHO meta-analysis, several randomized controlled trials that generally support the benefit of use of dexamethasone in critically ill patients. But again, the additive impacts of steroids and antivirals are unknown, but there are currently ongoing studies that are evaluating that question. So now I just want to turn to a couple other anti-inflammatory strategies that have been used. I think the one that has, actually received a lot of press and authorization for use with Remdesivir by the Food and Drug Administration, or FDA, is Baricitinib, which is a JAK inhibitor. And the figure on the right just kind of shows where Baricitinib acts as an anti-inflammatory. So you have JAK2 inhibitors that are in the circle, and then you can see where Baricitinib acts on a number of the different inflammatory pathways that affect innate antiviral defense, inflammatory responses, and so on. So, this drug was studied in the NIH ACT-2 randomized controlled trial, and it did show improvement in recovery time when taken with Remdesivir in hospitalized patients, but it was only by one day. And that is overall when you looked at the entire group. But when you actually narrowed it down to the group that was on high flow oxygen, there was actually a difference of 8 days in the recovery time between people who didn't get the drug Baricitinib and the people who did. So I think at this point, most guidelines agree that you should only use this drug in rare circumstances where corticosteroids cannot be used, just because of the strength of the corticosteroid data that I just showed you. So only in those situations, Baricitinib and Remdesivir should be considered. So another anti-inflammatory that has recently received a lot of press and discussions by different guidelines is the use of the IL-6 antagonist Tosylusimab. So this drug inhibits the IL-6 receptor that then reduces the inflammatory cytokine production. It is approved for the treatment of rheumatoid arthritis, and it is given intravenously, and it does have a very long half-life of 13 to 17 days. So it stays in the body for a long time. And then the adverse effects, which are of concern, are increases in liver function, enzymes, liver enzymes, and then also a possible increased risk of infections. And then in 2021, just in the last month, there have been a number of randomized controlled trials that have been published, but the data are mixed. I do want to bring up one of them, and that is the REMAP-CAP study that studied the use of Tosylusimab in a very specific population of patients that were admitted to the ICU within 24 hours and who required invasive or non-invasive mechanical ventilation or high flow oxygen. And in that group, they did show a reduction in mortality and a reduction in the time to ICU discharge. But several panels have been evaluating the data. There are a number of other RCTs that are randomized controlled trials that have been published that showed data that was otherwise. And so it really precludes a definitive recommendation for or against its use. But I will say, even on our NIH guidelines panel, there is a lot of discussion about this. And so the statement that was just posted last week about this drug on our NIH guidelines website says that, although there is no definitive recommendation for or against its use, some might administer single doses of the Tosylusimab in addition to Dexamethasone to these patients who are also exhibiting rapid progression. And the reason why is that the REMAP-CAP study is a more contemporary study where 80% of the people were also on Dexamethasone. And so that is kind of where that guidance is coming from. So, there will be more data coming out from the recovery study. So we're also anxiously awaiting that data, which should come out soon, and it'll probably give us more guidance regarding the use of this drug. So just to summarize the anti-inflammatory take home here, I think so far the best data supports Dexamethasone, and it looks like it has its biggest impact in intubated patients. And then the anti-inflammatories, as I've just mentioned, targeting specific cytokines to date have been mixed, and so we need more data in a contemporary setting. So, I wanted to just say a few words about oral outpatient therapy. We talked earlier about, monoclonal antibodies that are given intravenously and subcutaneously. It was a paper that's currently in preprint, but it is being reviewed for publication by a journal, and it is the use of Colchicine. And many of you probably have heard of Colchicine. It's an anti-inflammatory. It's used to treat gout. It has actually been shown to actually possibly prevent cardiac events. And so this group in Montreal actually studied it as a potential outpatient therapy for COVID-19. And the figure on the right shows the mechanism of action. And again, it seems to have some anti-inflammatory activity acting through the NALP3 inflammasome. So for this randomized controlled trial that included over 4,000 people, they gave patients colchicine, and these are patients who are over 40 years old with a diagnosis of COVID within 1 day and with more than one high risk criteria. And so they were given colchicine. Initially, it was 2 pills. One pill twice a day for 3 days, and then 1 pill once a day for the remaining 30 days. And so in the group of patients with PCR proven COVID-19, they found that the colchicine arm was associated with a lower risk of death and hospitalization. But the numbers were small amongst this over 4,000 people, 4,000 person trial of people who did get those events. So, I think the take home here again is that oral outpatient therapy that is effective and has been studied in an RCT, is happening, and there is potential. But I don't think colchicine is going to be a game changer either, similar to, the monoclonal antibodies that are currently approved for outpatient therapy. So hopefully we'll see more drugs coming down the line. So finally, I just have one really quick headline here, and that is that there is also emerging data on the use of blood thinners, full dose blood thinners, so therapeutic levels of blood thinners, and it looks like it is, has a positive impact in terms of decreasing the need for life support or mechanical ventilation, and it's improved outcomes in hospitalized COVID-19 patients. So this is just a press release from the NIH, as is some of the other new updates that I presented. I think it was interesting that earlier Mike showed the proliferation of published papers and preprints. We're also now getting press releases from different trials. And so I think there's a lot more to come in the next couple months in terms of updates with these existing therapies. And I know there are several others that people are looking at right now. But I think many of those drugs, such as ivermectin, fluvoxamine, as outpatient therapy, have been in very small randomized controlled trials. And so we need more before we can really start thinking about those drugs. So, just to conclude, there's still just a lot of unmet therapeutic needs. Where we've done well is in patients who are hospitalized and are critically ill, in terms of identifying drugs that have benefit in terms of speeding up recovery times and mortality benefit. Where we still need to work on, as I mentioned earlier, is the area of looking at oral outpatient therapy. I mentioned colchicine just now, but I don't think that's going to be a game changer in terms of the estimates that we saw. We also need more in the area of pre and post exposure prophylaxis. I think I showed you some of that data from the monoclonal antibody trials. Again, those are mainly from press releases. So I think we'll hear more about that in the next few months. And then therapeutic needs in non-pulmonary manifestations, and also now in the prevention and treatment of post-COVID complications. So I think there's much more to come in the next few months. And so, these are just some of the resources where some of this data were gathered from our COVID guidelines dashboard that Mike talked about earlier, and also from our IDSA guidelines and the NIH guidelines. Thank you.
Thanks so much, Dr. Tien. There have been a few questions that have come in through the Q&A, and in the last 10 minutes, we'll start going through some of those. For those who are online, please submit more questions through the Q&A, and we'll try and chip away at them. One of the first questions has to do with the monoclonal antibodies. You had mentioned that there are limitations in terms of their the ability to use them from a practical standpoint. I was wondering if you could comment on their heat stability, and then also the route of administration, sub-Q, intramuscularly versus intravenous, and how that might impact efficacy, or if that's known.
So right now, the data that we have is mainly, that has been published, is mainly through the intravenous route. The subcutaneous route, I think, that is currently being studied is for post-exposure prophylaxis. I mean, the data from Regeneron for the Regeneron combination looks very promising. I think the bigger issue with some of these monoclonal antibodies right now is the dosing. And so it requires a longer time for infusion. The other issue is the volume that is being given, especially in injections. I heard that for the injection, it is a 2 milliliter injection of the monoclonal antibody. And that is for one of them. And so for like Regeneron, you have 2 monoclonal antibodies. So I believe it is 2 shots of 2 milliliters. And so, it's really exciting to be able to give a shot subcutaneously. But I think there is still some work to be done in terms of the volume of the injection. But I think that is the most promising in terms of its use.
Thanks for that. The next question has to do with convalescent plasma and the potential role in asymptomatic patients, and how you think about utilizing in patients who either may have mild symptoms, and what the benefit is in that patient population.
So, I mean, it's been studied, I think, best in people who have had mild symptoms. But if you think about the mechanism of action of convalescent plasma, it is to reduce the viral clearance. And your peak viral clearance is usually like the day before you may develop symptoms. So, it probably has benefit in that scenario. But for now, the trials that have looked at it have looked at it in hospitalized patients, within 3 days from symptoms.
The next question is, are you aware of any recommendations for anticoagulants in COVID patients with other comorbidities like tuberculosis, for example?
Okay, I'm going to have to pass on that question. I'm not as familiar with the use of these anticoagulants in other co-infections. I don't know if anyone else can answer.
We can circle back to that one in a few minutes. Another question with regard to the recommendations on Remdesivir. WHO had released a statement about Remdesivir, and was wondering if you could comment on how that conversation has gone, and how you reconciled and that conflicting consensus statement.
Yeah, that's a great question. I mean, I think WHO was looking at the solidarity data, in line with the Act 1 data from the NIH. So, for example, in the United States and in our NIH guidelines panel, the fact that the NIH study was a randomized controlled trial led us to put more weight on that trial result. But I think, with the just to backtrack, I think it is really important to note, and I think I tried to convey that during the presentation, that actually when you look at the data between Solidarity and Act One, there isn't a lot of difference in that particular arm. It's just whether or not it reached statistical significance in the low flow oxygen arm. But I think as the World Health Organization, they need to be cognizant of the ability to administer remdesivir in a costly way in countries all around the world. Yeah.
Thanks. The next question. In Latin America, there's a big discussion around the use of ivermectin as prophylaxis and for the first phases of the disease. There are more than 30 studies in developing countries that have been pointed out here by our participant that show some promising clinical outcomes. Could you comment on the role of ivermectin in these studies?
Sure. So yeah, we've been reviewing like on our panel guidelines, the ivermectin data, and then we did put out a statement. And our initial review of ivermectin, we actually recommended against its use. In this most recent update, I think that was posted a few weeks ago, we do say now that there isn't sufficient data for or against its use. And that is because many of the randomized controlled trials were small in number. They just weren't adequately powered. And so, we were hopeful that there will be more data that comes out with that particular drug.
Thanks for that, Dr. Chen. And we are just at the end of the hour, so we'll go ahead and wrap up at this point. I want to thank Dr. Chen for her time and for all of you for joining, and for USAID and STAR for supporting this webinar. Please be in touch with us through email or in the chat if you have suggestions for future webinar topics. And please share with us your contact information. As Lauren had shared the sign-up sheet for this webinar so that we can make sure to send you the recording and minutes and the slide deck. Thank you again for your time. Have a great day.